Chairman. First, I apologize for Professor Nago Hazard. She should be with us today, but she has some illness after coming from Umrah last week, and she sends her regards. I'll talk about the challenges in business management, and we have seen some presentations showing typical forms or challenges in diagnosis of certain items in business. But now I'll talk about the general challenges facing us when dealing with busy patients. First, what's dizziness? Dizziness is defined theoretically as any impairment in spatial perception and stability. But clinically, dizziness is a non-specific term used by patients to describe a group of symptoms with different underlying pathophysiological processes. Epidemiology of dizziness, it's the second most common complaint in medical practice after pain, including headache. So it's very common. Dizziness is very common. The overall incidence is about 30%, and the average age is about 45 years. And with every 5 years above 45, the incidence increases by about 10%. That means that by the age of 75, 90% have dizziness. And dizziness is the most common complaint at this age. And given or considered the longevity and the increase of the human lifespan, we think that dizziness is very, very common, and it is the problem of dizziness is enormous. Dizziness is a diagnostic challenge, and we have seen the last two presentations talking about typical forms. It's a maze. It's very difficult to deal with some cases of dizziness. And also it is a clinical challenge. Sometimes it's frustrating and complex to see, and you see this doctor is afraid of dealing with a dizzy patient. Sometimes I have this feeling, especially a patient comes without reservation and complaining about dizziness at the last or at the end of a busy day. Usually I don't like to deal with dizzy patients at the end of a busy day. It needs some mental activity not present at that time. There are a lot of challenges in management of dizzy patients, and these are at least 9 challenges. Let's start by the causes. More than 120 diverse causes of dizziness have been reported to cause dizziness. And fortunately enough, more than 90% of these causes are benign in nature and not life-threatening. However, sometimes it is serious, the condition is serious and may be life-threatening, and this is the second challenge we face, that we don't take dizziness lightly. Sometimes it represents a serious condition or life-threatening condition. And usually it is biased to a central vestibular pathology at the central vestibular connections caused by inflammatory, plastic, vascular, degenerative causes, and this should be considered in every case of dizziness. As a result of the diversity of the causes, usually we can have multisensory or multifaceted cause of dizziness. So this typically happens in the presbyostasis or presbyovertigo, where not only the sensory vestibular element is affected, you have also the visual element and proprioceptive element, and also the central integration, and as well as the motor output. And this typically also occurs in cases of multiple sclerosis, where you face a dizzy patient with multisensory and multi-deficits. And then the challenge number 4, it's also due to diversity of causes. You have the referral dilemma. The referral dilemma is very important in our clinical practice. Sometimes you see busy patient after going to a neurosurgeon and then orthopedic and then neuropsychiatrist, and after they finish everything, they tell you, you might have something in the middle ear and go to your otology or otology. And this middle ear is a myth. It's a myth, you know, and very, very famous misconcept. And sometimes you have this conversation with your patients after doing the test and say, what do I have, doctor? You have a viral inflammation of the vestibular nerve. Okay, so what about the middle ear? The middle ear is fine. Fine. Why am I dizzy? Yeah, you are dizzy because you have viral inflammation of your right vestibular nerve. Yeah, let's just say that the middle ear is normal. How come? How come I'm dizzy? So the middle ear, and sometimes the conversation ends with, okay, you have a middle ear problem. Okay? So the middle ear problem that after doing everything and every laboratory investigations and CT brain and MRI, then you have something in the middle ear and goes to the otologist or the audiologist. So this is about 40% only of those cases finally go to otologists and audiologists. One of the challenges we have is different clinical presentations. You don't have typical presentation, you don't have a typical presentation, you have multiple presentations. And these are just presentations you might have. Dizziness of light and lightheadedness, episodic vertigo, sustained vertigo, positional or positioning nystagmus, or vertigo, oscillopsia, with auditory symptoms, with neurological symptoms, with headache, with postural imbalance, and even with different age group you have dizziness in the children that is, or pediatric dizziness that have peculiar causes and clinical features, and also you have geriatric dizziness that also have some other causes, and in young adults also you have some famous causes for dizziness. So dizziness is diversity clinically, etiologically, and we have also some forms of dizziness like wake-up dizziness, and this is common sometimes, that only complain about I'm dizzy only when I wake up in the morning. These have a lot of causes to look after. Because of this diversity of clinical presentations, some of our professors and researchers have tried to solve this problem by getting some classifications somehow. And one of these, my dear professor, Dr. Aziz Beg, he said this, the solve of dizziness maze. It's a maze, and he asked 5 questions, and these 5 questions, yes or no, gives you 10 possibilities. And you have on the and you have 10 presentations from these 5 questions. Acute with neurological, acute with audiological, and so on. This is not an easy task doing that, especially in basic clinic situation, but you have to because the diversity of the presentation. And after the GPS, Professor Blair invented what's called business GPS. And also it has the same concept, but where to go, not divide. So acute or chronic, and everyone positioned or non-positioned, and so on, to have classified your presentation. Sometimes we oversimplify the condition and say it's either fluctuating deficit or fixed deficit, or fixed deficit mimicking fluctuating deficit. And to oversimplify the condition in order to easily deal with such presentation. And we have also what's called the standing approach, with presence or absence of spontaneous nystagmus, the direction of the nystagmus with the V hat, and gives you 3 possibilities, either it's PVV or acute peripheral vestibulopathy or central vertigo. So all these approaches try to simplify the condition. One of these approaches, I personally prefer this approach because it's more clinical. That's you can divide dizziness into vertigo and non-vertigo dizziness. Vertigo either peripheral or central, and non-vertigo dizziness either syncope, it's related to vascular conditions or cardiovascular conditions, disequilibrium, and non-specific dizziness, which makes symptoms, and usually it is related or some psychogenic problem. And then the challenge number 6, which is vague symptoms. Sometimes the patient comes to you giving you some very clear description of what he feels, and sometimes they do not. Usually they do not. But all these vertigo, unsteadiness, disequilibrium, imbalance, syncope, lightheadedness, generalized weakness, motion intolerance, fatigue, blurred vision, nausea, they call it dizziness. Even mental fatigue or drowsiness, and this is very common. They usually make drowsiness instead of dizziness. Or this is not dizziness, this is drowsiness. I feel that I need to sleep, and they call it dizziness. This also leads to the challenge number 7, which is the huge differential diagnosis. We have multiple symptoms, multiple clinical presentations, multiple presentations and vague symptoms, and we need to narrow down the differential diagnosis, especially in clinical situation. So what's the key? The key is the history taking. And we had a wonderful presentation from Dr. Mohammed at the art of history taking dizziness. History taking is the most crucial part of your evaluation in a dizzy patient. You should instruct your patient that don't tell me you are dizzy. And describe your symptoms and don't tell me you are dizzy. Describe what you feel, don't tell me you are dizzy. I'm dizzy. And you should answer these 5 questions. When did it start? How long does it last? How often does it happen? What are you doing when it happens? Anything you can do to make it better or worse. These are the crucial 5 answers that should be answered during the history-taking session. And if you don't have clear answer to these 5 questions, you are in the maze of dizziness, and you might not get out. This is very clear area of how to analyze or interpret the history of the patient. Usually, we have one of these 8 presentations. Clinically, if you're taking history, if you take good history, you have either the 4 common presentations we have talked about: vertigo, unsteadiness, pre-syncope and syncope, vague symptoms, or you have motion intolerance, drop attack, balance-related fall, and orthodoxy. So these are the 8 presentations. I hope there is no other presentation, but you can summarize all the presentation, these 8, and every one of these has its own category and clinical description. Vertigo is very important. Why? Vertigo is very important, and you should be sure that it is vertigo and not any other form of dizziness, because vertigo cannot be non-vestibular. Vertigo is a vestibular disorder. No other way. If your patient has true vertigo, she is a vestibular patient. Of course, most of them are peripheral in etiology, some are central, and these are the common causes of peripheral central. This equilibrium is usually due to orthopedic or musculoskeletal problem. But usually, or sometimes, it can be vestibular. So all vertigo cases are vestibular. Some of the disequilibrium cases are also vestibular, about 50% of these cases. Pre-syncope or syncope are usually either vasovagal, orthostatic, or cardiac in origin, and they are not related to vestibular system in any way. The non-specific dizziness, within the fourth common presentation, usually the patient cannot tell you that it's vertigo or unsteadiness or imbalance or pre-fainting or fainting, something else other than sometimes it's psychiatric or psychogenic, maybe anemia, hypoglycemia, hyperlipidemia, sleep disorder. And by the way, sleep is or lack of sleep is the most common cause of dizziness in general. So we have these 4 types, and we have this common description in the other 4, which is dyslexia, moving of the visual environment, and these are usually central, but sometimes it happens in acute peripheral vestibular lesions. Fall or loss of postural stability. Fall and fall prevention is important, especially in the geriatric age, not because the fall itself, but because the consequences of fall in that particular age with many serious conditions that can happen. The drop attack, which is a sudden loss of postural stability, without loss of consciousness. And it occurs, of course, in some cases of hydrops or tonic epilepsy. Motion intolerance is a sensory conflict, usually happens in vehicles, cars, space, or cities. The challenge number 8 is the diagnostic tools and technology. There is clinical overlap between these conditions or presentations, and the question is how far to investigate. Usually we have clinical overlap like this dizziness, vertigo, pre-syncope. Sometimes these clinical presentations overlap, and you have to differentiate it with some diagnostic tools. We had 2 excellent presentations this morning about VAMP and VHAT, and these 2 are one of the 2 excellent tools to diagnose these patients. But as we said, that history is very important, and after history you should do some propagative tests. If you have rotating chair, do rotation-induced status, positioning, orthostatic, bedside test, and hyperventilation. All these provocative tests can give you some clue about the differential diagnosis, and then you have to examine the patient, otoscopy and audiological, and neurological examination, also systematic examination. And then the investigations, and we have the next session, we will talk about the investigations and the tools we can use in managing these patients. You have audiological, of course, basic audiological evaluation is a must, and vestibular. We have VHAT, VAMP, VMG, and posterography. You have to use at least one of these 4 tools. Not only one. You have 2 at least to prescribe. As we said that normal VMG does not exclude vestibular pathology. Normal VHAT alone does not exclude vestibular pathology. Normal VAMP alone does not exclude vestibular pathology. So you should have at least 2 of these to conclude the diagnosis. And we have also talk about radiology and lab workout in this division next session. And of course, we can need a specialty consultation in some cases. I'm not going to talk about bedside examination. Dr. Fatma gave an excellent presentation about bedside examination. But this is one of the how to use two tests. We can combine VEM, cervical and ocular VEM with the PEMG, we can almost cover all the parts of the vestibular system. So if all are normal, so you have no vestibular impairment. If all are normal, you have the entire end organ is affected. If only the cervical vein is abnormal, this is a secure vestibular nerve. If only the cervical vein is normal, this is superior vestibular and or lateral semicircular canal and utricle. If only the caloric is abnormal, this is the lateral semicircular canal. And if only the ovum is abnormal, this is the utricular dysfunction. So this is how to cover all the parts of the vestibular system. And then the challenge number 9, which is the most important challenge, how to manage, how to treat. And with such a disorder with different pathogenesis and different etiologies and different clinical presentations, you have to manage it properly. And sometimes we have this question, why to diagnose if beta-histine or synerzine can do the job? And this is completely wrong. This is completely wrong. To treat dizzy patients with beta-histine or synerzine or any labyrinthine sedative without diagnosing the condition. That's why this is wrong, because the main item in managing dizzy patients is the specific treatment of the underlying condition. And this you cannot know without diagnosing, without doing examination and different tools to have this diagnosis. So the specific treatment for the condition, either BPV, migraine, Meniere, whatever, you should diagnose the condition to give the proper treatment, and it's not the labyrinthine sedative. Something very important in managing dizzy patient is reassurance, information, and counseling. And I give this to the juniors. This is important in dealing with your patients. Sometimes the patient comes to you and he or she knows the diagnosis. Typical, for example, they have Meniere disease. I know I have Meniere disease. I have read a lot of papers and a lot of websites about Meniere disease, but I come to you to reassure me. Give me some counseling. What can I do? How I live with Meniere disease? They said to me that you will live with Meniere disease and you will have this business forever. It's something frustrating, something frightening for the patient. And reassurance, information, counseling is very important, and sometimes give better prognosis or better results for your management. Of course, vestibular rehabilitation, and finally, non-specific drug treatment for acute vertigo, nausea, and vomiting. And this is the only condition you can give beta-histine or synerzine. In acute vertigo, patient have acute vertigo with vomiting and nausea. You can give now symptomatic treatment to treat vertigo, nausea, and vomiting. But this is not the treatment of dizziness. Okay? The take-home message that history taking is very crucial and gives you a clue in some 80% of cases. You can reach some primary or preliminary diagnosis in 80% of cases. Examination does not make the diagnosis, but in most of cases helps to confirm it. And you need to, from history taking, any examination, to select some worked-out laboratory or radiological or in vestibular or audiological, according to what you have taken from the information or knowledge from history and examination to select these assemblies will give you some help in managing these patients. Thank you very much.